Toni is in charge of the palliative care at Kootenai Health. And I just want to say, from my experience, not only as a cancer guy, that don't be afraid of palliative care in hospital. I know I've had many men and women that I have met and mentored go to hospice, and I've come home with them. You know, it's not a death sentence. Palliative care. I guess the point is this, that to be a cancer survivor, the road may take you through palliative care and hospice. Doesn't mean it's over. It just means that's the exit you have to take on your way to survivorship. Okay? So, no more preaching from me. I'd like to introduce Toni James. Thank you.
So, yeah, I work at Kootenai Health. I am one of the palliative care nurses there, and I have a team I'll introduce in a couple slides here. But I think the objectives for tonight that I wanted to cover is to talk about a supportive community resources that palliative care can provide. Who is out there that you can call, and when should you call them? I'm going to encourage you, when we talk about palliative care, people often come to a meeting with me with preconceived notions of what palliative care is. I would encourage everybody to come to a palliative care meeting thinking about it in terms of their goals, because that's the nuts and the bolts of palliative care is what are your goals and what's important to you right now. We're going to talk a little bit about advanced directives. And that's kind of documents that can help you be in charge of how things go in different medical situations. I do have a couple of handouts in the back if you're interested. One that talks about advanced directives and the few different types that there are. And there's also a little sheet that talks about the North Idaho Palliative Care Coalition. COVID kind of squashed it and we're not meeting currently, but we do have a website, and on that website you can get different resources, including living wills and stuff like that if you're interested in completing those documents. So that stuff is back there, along with a couple of my cards, if that is helpful. If you have questions at any time during the presentation, just please let me know so that we can pause and just talk while we're in the moment there. So I think of palliative care as one of the tools in the toolbox to help you as you are living with a chronic illness. People often ask what palliative care is. A lot of people don't know what it is. And palliative care, folks like me, we work with folks who have serious or chronic illness. And we talk with them about what their treatment wishes are. We talk with them about what their treatment options are. That means that I have to talk to the various care people on the care team, right? I have to talk with the doctor. Maybe I need to talk to the dietitian, maybe the physical therapist, any of those important players that are helping a patient right now. I need to talk with them and know what they're seeing when they do assessments and what they're planning for the future, so that I can talk with a patient about their treatment options, making sure that they understand all the pros and cons of those things. And then comes the part where we talk about what's important to you and what are your wishes. And then in palliative care, we take that back to the care team and make sure that the people that are taking care of somebody knows what those wishes are and what's important. Does that make sense? So we do discuss what's going well, what could be better, and what could be better is a specific, that's a particular point of interest. Palliative care tries to focus on quality of life and making that as good as possible while you are living with a chronic illness. And so what could be better? Maybe there's some resources that we need to get you in touch with, or at least let you know about so that you can consider if you want to think about reaching out to those resources. For example, we help with advanced directives, as I said. Symptom management is a piece of that. At the hospital currently, I do not have a medical director. Unfortunately, we haven't had a medical director for a number of years. We had a couple of possibilities, and then COVID, changed all of that, and we haven't had any good takers again in a while. So while for symptom management, you kind of need to have a palliative, like a board certified palliative physician is top notch. But there are other folks who are savvy with symptom management too. Certainly the oncologists have a good leg up on all of that symptom management. On occasion, things get a little difficult to handle, and that palliative doctor is helpful. We do have some resources, and I can talk about that when the slide comes up, for symptom management. And then in palliative care, we do end-of-life care as well. If you think about palliative care as an umbrella, all of these things like advanced directives and symptom management and end-of-life care are pieces underneath the umbrella, if that makes sense. So I work with people that have a chronic illness at any stage of that illness. And a common example I use is somebody who's newly diagnosed with cancer who is planning on getting treatment and trying to get a cure for their cancer. I work with folks like that, and I work with folks that have any chronic illness who are saying, gosh, at this point in my life, I'm wanting to go home, stop worrying about the doctor's appointments and all of the blood work and the things like that, and I just want to be comfortable in my home, and I want to call the shots of what I can eat and all of those pieces. So I work with any of those folks that have a chronic illness. So there are several palliative care teams in our community. I think when I came and joined the support group the last time, that was many years ago, we had not very many visiting palliative care teams, and we had a outpatient palliative care doctor, and that's all changed. But we do have multiple palliative care teams in the community that will come to you. And so to get connected with one of the palliative care teams, you do need a referral from your physician or could be a nurse practitioner, any provider level person. You would just need to, and that could be your oncologist or it could be your primary care provider too. So if I talk a little bit about the different palliative care options, for folks who are admitted at the hospital at Kootenai Health, myself and my team can go and help those folks that are there. There's 4 of us on the team currently, so 2 nurses and 2 social workers, and we have kind of, in palliative care, there usually is a team approach, and we all kind of have a core base of palliative care knowledge and training. And then, a visit from me is going to be different than a visit from my social worker, Jan, though, right? Because I talk more about the medical piece and symptom I can start those conversations about symptom management, although I don't order medications. Where my partner, Jan, can talk a lot more about the psychosocial piece of it and the mental health piece of it, that is just so common with folks that are living with a chronic illness. So it is a little bit different, and so we use our skill sets depending on what any of our patients might need. Community palliative care, there are, I believe that I have all of them listed there. So community palliative care is a team that exists out in the community with one of these various agencies, and they come to you. So they can come to your home, or sometimes folks are, at a rehab facility. If you've been hospitalized, it's very common to go to a facility for rehab before you get back home. And so these folks can come and visit you at the facility. Some of the patients that we work with live at assisted living, or even have long-term care at a nursing facility. And so these teams can go to any of those facilities to check in on folks and see kind of, are there any new needs that have popped up. And then say if you were at rehab and you got back home, then they can just come to your home as well and just check in with you. Each of these teams are a little bit different in who's on the team. One of the first things I like to point out to folks is that many of these teams do come from one of our local hospice agencies in town. It is very different service. I believe in a slide or two I talk about hospice services in detail. The palliative care team is very different than signing up for the hospice services. So Advanced Healthcare, that's actually a facility down at Riverstone. You may or may not be familiar with that. They have a palliative care team there. They have a palliative coordinator who can see patients there at the facility, and then she can also go see patients at other facilities and at their homes. Auburn Crest Hospice, they have a nurse and a social worker are on their team. When I have somebody who needs palliative care who has a heavy symptom burden, something's going on that's proven fairly difficult for us to get a handle on, and we might want to have somebody to keep tabs on it over the next days and weeks, as we're sending somebody out of the hospital. I kind of like Auburn Crest Hospice for that, because they do have a board certified palliative and hospice physician there that I used to work with probably around 2006, 2007 at the hospital. And I've seen him multiple times working with patients, and in my opinion, he just has stellar symptom management skills. And so when somebody needs a lot of symptom management, I kind of think maybe he would be a good one to connect with. Gentiva Hospice, I just have these listed in alphabetical order. Gentiva Hospice, they do have a palliative care team. They're a little bit newer to me, and I'm not as familiar with their staff. I believe that they have a palliative coordinator that's in charge of that team that comes out and can make visits and check on, how you're doing overall, and try to make some connections if there's some rough patches going on with your treatment plan. Hospice of North Idaho, they have their palliative care team has a nurse practitioner and a social worker. So again, you do have another option for somebody who can come and do assessments of symptoms and help work with your primary care provider or your oncologist to make recommendations and help you get medications that might help if you're having struggling with symptom management. And then the VA, for any veterans, they do have a palliative care team. Their palliative care team is out of Spokane. It's telehealth only, so they do not make visits in person. It is a very robust team. They have physicians, they have nurse practitioners, they have chaplains, they have nurses and social workers. Like when you think about what is a full palliative care team, that's it. And so they make a phone call, like a conference, and it's one that you schedule, and you would tell like who's your support system. Is that your family or friends or whoever is supporting you through your cancer journey? That you would have them all together for the phone call, and they would go through, and it's a really lengthy dive deep into all of your physical issues, the psychosocial stuff, the caregiver needs, stuff like that, and the mental health piece of it. So all of those aspects are addressed, and they take up a good long time. And I think they call people once every 3 months, if I remember correctly. So you've got some different options there. for care. Let's see. And I think I covered everything on that slide. So, how does palliative care help? What can you expect when you have a meeting with palliative care? The first thing, and it's maybe not a cookie cutter. I can't be certain that all of those palliative care teams do everything just the way that I do it. But in general, I think that, basic palliative care training would say the first thing is, to find out what somebody knows about their illness and their current status. What has the doctor been saying is going on? And then just letting the person talk for a while and make sure that what the person I'm meeting with, make sure they're saying something at least that at least resembles what the doctor told me, right? And if there's any big red flags, then I'm going to work to figure out how can we clarify to make sure that what my patient is talking about is the same as what their doctor is talking about. And as I said, we spend plenty of time just talking through treatment options and the pros and cons. Sometimes, and we spend, when I say plenty of time, really that isn't up to me. That's up to the person that I'm meeting with, right? Some folks they're well informed what's going on. They know what their treatment options are, and they just needed to sit down to hash out just a few details, and they know what they want. Other people don't have the same understanding, and they need a little bit more discussion about what those treatment options mean and what that might look like in their life, for example. And so I just take the time that the patient that I'm meeting with needs. Navigating the medical system is a big part of palliative care and getting connected with helpful resources. Some of the things that I talk about with my patients at the hospital are, if you get back home and you're trucking along, but then some kind of symptom pops up or you need some sort of medical equipment to help you get along better at home. Those are some of the things that a palliative care person can help get you connected to the people that can get that for you, right? Make the phone call to the doctor or to the home health team or the physical therapist and get those needs addressed. And sometimes an important piece of what we do is helping families to just sort of facilitating important discussions. Sometimes it's, the patient might say to me, "Don't tell my kids so-and-so." And then when I'm talking to the kids, they're saying, "Don't tell my mom, that this is going on." And I understand family dynamics get really complicated and it's very tricky for all of us that have families, right? However, when you're dealing with chronic illness, we want to open up the communication so that you've got the support that you need, and it just makes things less rocky, maybe down the road, if that makes sense. If who you choose as your support system, if you can just have good communication. And sometimes those conversations are tough. I don't know if maybe you guys have experienced if you're talking to your doctor and the doctor's saying a lot of things, and then you're supposed to, or the person that came to your appointment with you is supposed to help translate that to all of the family, and that is sometimes a tall order, right? It's a medical lingo. It can sometimes be like a second language, and so that's a tall order for somebody who's dealing with this illness and all of these things that are coming up, and I'm supposed to now try to figure out how to say all of that to my family. That's another thing that palliative care can do, is just helping to facilitate those conversations so that everybody has the information that they need. If we talk about advanced directives for a minute, does anybody else besides me have their advanced directive completed? Thanks. Okay. Very good. So there's a few different types of advanced directives. Living wills are, that's a document, it's a 5-page document typically. It varies a little bit, but it's typically a 5-page document that talks about different medical situations and what kind of care would you want if these things happened. And so you can use these to say, if I get drastically ill and the doctor is really worried that I'm not going to pull through, and you can say, I would want aggressive care to continue as long as possible, or I might want to put some boundaries up and say, I want to continue care only until this point, some things like that. And that the living will also includes the power of attorney for healthcare, typically. These forms, you can find them two separate forms. Often they're put together into one form. And so a power of attorney for healthcare is somebody who you say, this person knows what my medical wishes are, and I trust that if I became so ill that I couldn't wake up and talk for myself, this is the person my doctor can talk to who would advocate for treatment that they know that I want because we have talked about it. And so that sometimes gets a little tricky. Now and then I work with families that tell me, well, I'm the power of attorney, so you can just talk to me. That's only sort of true. The very first thing is we always talk to the patient anytime the patient is able to wake up and talk and understands the consequences of their decisions. They can understand the conversation and also understand the consequences of decisions. Only when that's not happening would we then talk to the power of attorney for healthcare. And that healthcare person can only help make medical decisions under those circumstances. It doesn't give this person access to any financial, like you're not going to be able to pay the bills. Like if you're somebody's power of attorney and they're in ICU incapacitated, you are not going to be able to pay their bills for them, like, use their checkbooks and access their money for stuff like that. It doesn't give you access to any of that or have anything to do with the estate. Just the medical decision making, and only if the person that you are power of attorney for cannot participate in that conversation themselves. A post form is a physician's order for scope of treatment, and that's an Idaho form that is, I often hear that called a do not resuscitate form, and that's probably a decent way to think of it. When I'm talking with patients, I tell them that unless you want to put up some boundaries of what kind of care you get, you do not need a post form. Any of us by default, if somebody finds us down and our heart isn't beating, we're not breathing, we're going to get, like when the ambulance comes, we're going to get full CPR and life support used on us, and they're going to take us to an emergency room and try to get us into ICU. So that's full aggressive care. That's what all of us would get unless you have, some way of letting the ambulance crew know that we used to have a lot of bracelets or necklaces that would say that you didn't want to have CPR done to you, that's what do not resuscitate means, is I don't want CPR done to me. So if I'm found down, not breathing, no heartbeat, do not use CPR. Do not attempt to resuscitate me. So that's what the post form is for. And you can talk about other things in there too, like if I'm sick, my heart is beating, I'm breathing, but I'm sick, do I want to go back to the hospital and get treatment and evaluation? You can check that. You can, but don't take me to ICU, or you can say, I want to go to the hospital and get treatment, and I want all the aggressive care that I qualify for, all the life support I qualify for. And there's an option for folks that say that they do not wish to return to the hospital if that's at all possible. They would rather stay home and be comfortable, call my hospice nurse in, and my time could be short because of that. And so it just gives you some space to kind of show what your wishes are. There's also a spot on there for you to check yes or no to things like a feeding tube, IV fluids, antibiotics, blood transfusions, some things like that. The post form is a single page, and it's got check boxes, so it's very easy for a first responder to look at that and have a good picture of what kind of care this person in front of me wants to have happen for them. A lot of people that I work with think that when they do the 5-page document, the living will, A lot of people will tell me, I already have the DNR because they filled out that 5-page document. If you use the living will to say that if I'm super sick and the doctor doesn't think I'm going to pull through, do not do aggressive treatment for me. The first part of that document says a doctor has checked me out and they are worried I'm not going to survive. So if an ambulance shows up, there's not a doctor there that's checked you out and has decided whether or not they think that you're going to survive. So that 5-page document would not protect you from getting CPR if that was something you did not want. So I just like to I just like to point that out so people understand the difference of those two things. An important question for everybody, you can think about it to yourself, is do your adult children enjoy the company of your non-married partner if that situation applies to you? The reason I like to point that out is because if you have a non-married partner and your children do not like them, if you get drastically sick and you can't speak for yourself, your kids are going to be the first people in line. If you do not have a living will or power of attorney, your kids are going to be first in line by the Idaho law of who we go talk to about what should happen to you. And we don't know anybody's dynamics. And so if the kids say, oh, mom's husband, he's no good, he's never been any good for her, and he's not allowed to visit, and he doesn't get to say anything anything about mom's care. Well, if you can't wake up and tell us that's not true, and I do want my life partner that I love to be included in my decisions, or that's the person I spoke with the most about my wishes, that's who should be calling the shots, not my kids. We don't know any of that. We just go by the legal hierarchy, which would direct us to your children. So that's another little piece I like to arm people with it's all about just giving you the information so that you can have the control, right, over how these things could potentially go down if there's any monkey wrenches. So what about end of life? I sometimes get a question, does palliative care ever tell you that you have to sign up for hospice now? And that is a really important question. The short answer is no. Palliative care never tells you that it's time to sign up for hospice. And I'll go a step further and say nobody can ever tell you that you have to sign up for hospice. And when I'm teaching at the hospital, I always make a point to belabor this because it's not always just like common knowledge that patients always get to choose what happens to them. Just because you qualify, people can often qualify for hospice before they're ready for hospice, right? You might qualify for hospice, but even if you do qualify for hospice, that does not mean that you have to sign up with hospice. I spend a lot of time in ICU, and I work with plenty of folks who qualify for hospice. And when I go in and talk with them about their treatment wishes, and they're telling me that I want to have CPR. If my heart stops, I want CPR. I want to pursue aggressive treatments. That's what I come back out and talk with the team about. Because it's about what any given patient wants to have, and you get to choose. All of these things, hospice and all of the other things, those are tools in the toolbox. And especially when I'm teaching like other nurses at the hospital, and that is, what my life experience has led me to believe is a good toolbox, the best tools to have if I am having a chronic illness or if I was at end of life. My tools are not the same as anybody else's tools. And that is okay. And I don't have to try to get everybody's toolbox to match my toolbox. And so I think sometimes that is a surprising concept for medical people, unfortunately. But I think that they're easy to come around when you just, help people to understand, no, that's not what's going to work for me. And what I see working for me or what I want to try to do is, and you lay it out, then your team should respond to you in that way. Because people always get to choose. And when things get tough, if you're walking that rough road, like Jim says, you're fighting to see another sunset or sunrise for any reason. Return to what is important to you. What are the things that you value, and what are the things that you want to work towards? Because we can build a plan for that. Always thinking about what you are hoping for. And I also like to point out there's always something to hope for. I sometimes work with very, very sick patients in ICU or anywhere in the hospital, where they or family members might sometimes say that there's nothing to hope for. And that's not true. There's always something to hope for. Sometimes when the road gets rough, we have to think about if what we wanted to do is not within our grasp anymore, what can we hope for? What should we hope for? There's always something. Sometimes that might be if somebody is at end of life. Sometimes that might be what would a peaceful situation look for you if you're at end of life? Would that be being at home surrounded by your family and your dogs, which was a situation I was just dealing with at the hospital recently, and then we try to rally behind and let's try to make that happen for somebody. Or maybe it's Jim talked about going to every birthday party, and is that something that you can hope for? There's always something to hope for. Sometimes when the road gets rough, though, you have to regroup and think about, okay, this is where I'm at. I wish I was in a different part of the path, but this is where I'm at. What am I going to hope for right now, and what is important to me? And then what tools do you have to help you achieve that, if that makes sense? To talk a little bit about hospice, just so that you have the information, and perhaps some of you have had some experience with hospice. So you have a team of people that typically go to wherever you're living, right? There's hospices typically have a medical director or a provider that's in charge of, so that they can write the orders and stuff that might be needed. You have a nurse that is on call to you 24/7 that can come out to you. The nurse will plan to come out to you. If things are going well for you, the nurse is probably going to want to come out at least once a week. If you hit a rough patch, like you might have to call the nurse at 2 a.m. Something, some new symptom or something's going on, and what I usually do to help this isn't working, and I need help. And so they would come out and try to patch your symptoms up. Does that mean they have to call a doctor in the middle of the night to get some medication orders or whatever that might look like? They do that. And then they might need to come out every day for a few days to make sure that we've got everything under control. So you've got a social worker that would come out too. Social workers are great because they know what all the different resources are. They can help us with like what does insurance cover and all of those things. And social workers are also great, like mental health practitioners, right? And so they do a lot of that anticipatory grieving work with not just the patient, but also everybody who loves the patient. And so they are dealing with that whole group of people. Some folks like to have the chaplain be part of their team, and so the chaplain can make visits. There are bath aides that can come out if mobility gets difficult, bath aides that can come out, help with the bathing a couple times a week or so. You kind of meet with the team and you figure, maybe it's the nurse or the social worker, and you get to choose what does hospice look like for you, who's on the team. Maybe not everybody wants the chaplain, or we've all heard about, somebody's on hospice and they get the hospital bed in the living room. A lot of the folks that I work with at the hospital say, I'm going to be in my own bed. So again, you get to choose all of it and what that looks like for you. So it looks different for any given person. When you sign on to hospice, You do sign on for a 6-month period. Any equipment that helps you function better at home, they pay for the rental of that equipment and deliver it out to the house. That's where the stuff like the hospital bed comes from. But maybe it's a wheelchair, some oxygen, a shower chair, walker, maybe a pain pump, any of that equipment that helps you be more successful at home. They rent that for you and bring it out. Any medications that help you feel better today, they pay for those and pick them up at the pharmacy and make sure that you've got your medications. So just take some footwork out for either you or your caregivers, whoever's supporting you through all of that. I always think of a couple. I always like to think of a couple of examples. So something like glaucoma drops. If you have glaucoma and you take drops, and you don't have those drops, your body's going to notice it pretty quick, and you're going to start to have pressure and pain. And so glaucoma drops would be something that you need to continue if you're on hospice. Same if you have, like if you had, AFib, where your heart rate gets really fast and doesn't beat properly. If you were to stop that medication, if somebody's on hospice, I think people often think when you're on hospice, they just stop all of your medications. You need to actually go through the list carefully and stop the things only that have goals for years down the road, like statins, like cholesterol medication and stuff like that. If we stop somebody's AFib medication and so their heart gets really, really fast, that can be uncomfortable because they could have sensation in their chest. They could get dizzy, they could fall down. That's not good quality of life. So those are just a couple of examples that I use when we talk about hospice wanting to maintain quality of life as long as possible. But it's not just stop all of your medications and take away your, you can't go to your doctors. I just worked with somebody who they had an experience with hospice where they were told that they didn't need to go see their foot doctor, they didn't need to go see their primary care doctor, or maybe it was their lung doctor. And then you just need to take these comfort medications now and be at home and be comfortable. And the family thought, but he's not really all that uncomfortable. And when he's awake, he's playing games on his tablet and he's enjoying his family and his dogs. So why does he have to take that? Why does he have to take morphine or comfort medications? It doesn't make sense to them. And they couldn't get the team to understand, and so they just signed off a hospice and said, thanks, but no thanks. It's just not a good fit for us. And I think that's just an example of not listening to what somebody's trying to tell you they want for themselves. It's very true that hospice is not just a bucket that we put people in and everybody goes in the same bucket. It has to look different for everybody based on what you need. And so if you should happen to get connected with a team that isn't listening to you, then you don't have the right players on your team yet, right? Because they need to listen to you. That doesn't mean that people won't give you hard information sometimes. But if you don't feel like taking morphine when you're on hospice, you don't have to take morphine on hospice. That's your choice. The other thing about hospice I like to point out is at the end of 6 months, if somebody's still trucking along on hospice and it's been 6 months, hospice will send out the provider, so that's either the nurse practitioner or the doctor, to do an exam and an assessment and ask what's called the surprise question. And the question is, would I be surprised if this person were to pass away in the next 6 months or so? And if the answer to that is no, I would not be surprised by that, then sign on for another 6-month period. And there's no limit to how many times you can sign up for hospice for those 6-month periods. So I've known somebody that was on hospice for 2 years. I just met a gem of a lady this week who said, well, I was on hospice for 2 or 3 years, but I signed off of it because I was doing good enough and I didn't think I needed them anymore. And then she was talking to me about signing back on hospice. So those people do exist. Jim alluded to that too. Those people do exist. And then too is if hospice doesn't feel like it's a good fit for some reason after after somebody is signed on, you can always sign back off. You're not locked in to any of these decisions. It's always will. You make a living will, and then you decide that's not your wishes anymore, or that person, you don't trust that person to follow through with your wishes. You can always change those, so that you're never locked into any of these decisions. Hospice choices. Did I update that? There's Hospice of North Idaho, Auburn Crest, and then, and then just multiple. We have several home health agencies, and I listed them before. The ones that have palliative care, they also have a hospice department, and so there are several options. They all should provide the same home care services. It all should be fairly comparative. Hospice of North Idaho is the one that has the hospice house that's out on Prairie. That is the only hospice house in the state of Idaho. And so if people like that as an option, just good to know that that's hospice of North Idaho. You guys didn't have any questions during all of that. You let me say a lot of words. Are there any questions that you are thinking of right now? Or was there anything that you might have had a question about palliative care that I didn't address? Yes.
So, when someone has power of attorney, they may choose that person not just because they may become incapacitated and can't answer, make those decisions. Say they have a medical person in their family, and they trust that person to ask maybe even more detailed questions than they know to ask. And so, tell me about how that would work, where it sounds like the preference is we just want to talk to the patient unless that patient can't talk to themselves. Yeah. But they may say, I want you to talk to my husband, my brother. And sometimes, the medical staff are like, no, we're going to just talk to the patient. So talk about that a little bit. How to navigate that.
Again, I think we can always defer. A patient can always defer us to go and talk. Like, I want you to talk with my daughter who's a nurse or a doctor. Whenever I encounter that, I'm always happy to give those folks a call, because I think it just makes sense that any clinician that is meeting with a patient, you can't take that patient out of the context of their family, right? Or whoever they identify is their support system. You just can't remove them. They're not just a person by themselves existing with some illness, right? And so you have to keep all of that context. And so I just had a gentleman the other day I was asked to go see because he said he wanted a biopsy, and the daughter said that he doesn't want a biopsy. And so go figure that out. My first question was, is he decisional? Meaning that he can partake in the conversation and understand the consequences of the decision he makes. And the doctor said, he seemed decisional to me. So I go talk to him, and right off the top, he points to the whiteboard in the room and that had a message on it that said, please call my daughter for any medical information and discussion. And so I realized, I said, I think you're telling me that you're pointing to that sign that I should call your daughter. He said, yes. And so I said, I will do that. I'll talk with her. Do you want us to follow her instructions that she tells us about? Because I had mentioned the biopsy. And he said, yes. He said, he had hearing issues, and I think that he was a little overwhelmed and fatigued with everything going on. And so, I called up his daughter, and she told me, we've had these conversations multiple times. I know what my dad wants, and he said he doesn't want surgery and all of these things, and so he doesn't want to get any invasive workup. And so, absolutely. And then when I clarified that with, I'm telling the doctor that, and he was like, that's not what the patient told me today. And I said, but he told me that he wanted us to follow her instructions, that he valued her, but he wants us to follow her instructions. And so to me, a patient, we want to take our cues from the patient always, first. But if the patient defers, we definitely need to honor that request. has too.
I think it's a little bit more challenging. I think many of us are outpatients currently.
Mm-hmm.
So having a family member who may be more knowledgeable about asking better questions, come with you to your oncology appointment or call afterwards and have a question. And sometimes you can encounter that roadblock. So I was a little concerned that even with a power of attorney, you can still encounter a roadblock. I've experienced this myself as an outpatient.
I think that is possible, and I see a lot of people, and I'm sure you've seen this too, be uptight about HIPAA rules. And so, especially if somebody, like if your family calls the clinic to say, "Oh, hey, I wanted to clarify something," or
right.
That's going to be difficult. I think that when you go in with a family member, a couple of things is you may want to identify to the nurse, to the provider, and say, this is my trusted, support person, and they're here to help me retain the information you're going to share with me. They're also going to help me just explain everything to my family. And if they have questions, I want them to be able to get information. And so is there a form I need to sign? There could be a release of information that this person, at the hospital there certainly is, and I would assume at the clinic there is too. Because everybody's bound by HIPAA rules, and sometimes the staff just gets so uptight about not wanting to be in trouble and violate anybody's HIPAA rights that they will just shut down overly. So I've seen that many times.
You've got to ask them to double check that release of information where you indicate you can talk to this person. Some people, as they go through this, they don't want to get overburdened with information or statistics and all of that, but maybe a family member could hold that information for them.
Yeah, absolutely, and I think that's a good point, because that is a common issue of not getting access to information.
Keep pushing for that. Yeah. There is a way to have
and
a loved one be able to think and ask on your behalf if you're trying to keep your headspace different and positive.
Yeah, for sure.
I just wondered if your group, I don't know if you have anything to do with this or not, but we have a situation where I have a sister and a sister living now. Her sodium level dropped and she got sick and was in the hospital forever, and they moved her to a lockdown place because she escaped the hospital. Anyway, she has one daughter who has power of attorney, and she's just not following through what she's supposed to do. She's kind of blowing all her money, and we don't know really what to do with that. Is that something your group gets involved with? Or?
Not specifically, but is your sister, does she have memory issues?
Some of us think that she's okay, but she's very angry and she wants out of the place, which they say all of these dementia patients want out. But we just don't really know. I'm sure she does because of things that have been said. I know, and it's just bizarre. This is my second sister with this disease, and it's just, I don't know. Maybe we feel like she should be able to go home, and why not? I don't know. But the real issue is that her daughter, who has power of attorney, is not taking care of her. She should be seeing a neurologist. All kinds of things that should be done. And
I guess in that situation, I might be. I guess I would be thinking about getting in touch with staff at the facility and maybe asking for a care conference. And that could be tricky if your niece says, "Heck no, I won't go," or
she doesn't want to do anything. Just let her.
The other thing you can consider is getting a guardian for your sister. You have a lot more authority than the power of attorney does.
Really? A guardian?
A guardian.
How do you go about getting that? Because she needs one.
I just finished the process for my father. So
really?
I did that this year. Yeah, and it gives you the right to and the responsibility to look out for the person. Where they live, make sure all the needs are being met.
Who do you call? Like, do you have to go through a lawyer, or who do you call to get a guardian?
I did have an attorney.
Okay.
Yes. elder law can help with that, right? I think, well, yeah, is that is that an attorney's office or is that a state? Oh, it's a type of law. It helps. Right. Any attorney that specializes in elder law.
Okay.
Be able to help you.
Okay, that'd be great. She's actually in Spokane, and I don't know if that makes a difference or not, but okay.
That might be something you can consider, but she might contest it. You know, if you try to step in, and it is a good responsibility. All of those things you're talking about, the daughter isn't doing. If you want to advocate, all of this is required. You can also do conservatorship.
Yeah, that's the worry. I mean, it's bad. I'll check into that. Thank you. You know, I was going to say the living will thing. I kind of got stuck on that because I thought, you know, when we do our wills and we get our living will, we're younger, we're not sick, and we feel good, and we're like, no, don't keep me alive. I don't want any of those machines on me. Just let me go. And then you get to that point, and
you start to open your mind a little
you
bit.
can't really talk. You know, that's another sister I went through who, in the end, she couldn't talk. I don't know if she was in a coma or what. She did not want anything. But I kind of felt like maybe she did. I don't know. Does that happen where people change their mind and then?
Well, yeah, people change their mind. It's a good idea if you have a living will or some directive to review it at least every 10 years. If there's a new health diagnosis or new status change, like if you are experiencing a change in your body, that's those are milestones that you want to review it to make sure it's as current as possible. Because we fill those out when we're young and healthy and nothing's wrong, and we just know that we want to, we don't want to have any encumbered, lifestyle. But then you develop, some kind of an illness that you're confronted with having limitations. You might change your mind about that, and so you can definitely update those, and as often as needed.
I mean, with people with cancer, I know how he filled his out, but I see how he's fighting. Which I'm really glad for. He's doing a good job fighting this, but I think, why would you fight to live? But the living will says no.
And it could be that the living will says, if the doctor has examined me and is worried I'm not going to pull through, which is very different than fighting with the ups and downs on the journey of like a cancer battle, right?
Yeah.
So it's that's a little nuance there that might not. That's why people think that often that living will is it's their DNR form, their do not resuscitate form. That's not true. Now the folks that say, the folks that say they don't need a post form, they want to have CPR done to them, but their living will says I wouldn't want aggressive treatment. That says to me, this is somebody who, if they're found down, they want to be resuscitated, and then we try to get them to ICU and hook them up to whatever life support they might need. Often that's the breathing machine, and then the team starts to figure out what just made that happen and can we fix it, and then hopefully after a day or 2 or 3, that life support is coming off. But if it's not, that's when the living will we start to look at that and talk about that with the family and say, if they didn't want that, that aggressive care to continue, that's when we need to start thinking about somebody's wishes and make sure that we're honoring their wishes and not stepping on them. What started off as a good intention of we might be able to figure this out and reverse this. Does that make sense?
Mm-hmm.
some people don't want to take that chance. It just depends on whatever your life experience is, right? I work with some people that they don't want to roll the dice and take a chance of getting resuscitated and, maybe living with they don't pass away, but they are living with a severe brain injury now where they have to be in a nursing home.
Yeah,
Some people don't want to take that chance, and other people say, thank goodness we took that chance because my dad is still alive and he, is living with deficits and maybe he is living in a nursing home, but thank goodness my dad's still alive. So it's all, people think about it so differently. And so that's where it's just important for each of us to think about what's important to us and then, make sure we share that with our support system and know what the tools are that we have available to us. And sometimes best laid plans because, I worked with a lady whose mom had MS, and so they had all these conversations and she knew exactly what she wanted, that she would probably have swallowing problems, and she said no to a feeding tube and no to getting the life support put on her. And then I don't remember the details of that case, but that's not what happened to her. It was something completely different. And the daughter was going, geez, this wasn't supposed to be the conversation, but the important thing is to have those conversations, just to give your family or whoever your support is an indication of what's okay for you and what might be out of balance. And that's kind of the best we can go by. Sometimes it's a hard position. Being a medical power of attorney is a hard position to be in.
I have a question about care intrusive. I've heard that I've read that there's often just hospitals and hospitals that are lacking palliative care teams. And then there's also the other side of it. I've also read some things where people think that people are being referred to palliative care, they don't necessarily need it. But in terms of dealing with cancer, would you say that if someone receives a diagnosis that is terminal case of cancer, but they can be treated, but they're not going to be cured, they eventually die from that disease, and they, at the time of diagnosis, they have a good quality of life. When would you suggest that they look into palliative care? Would it be right away just to develop a rapport with the team, or would it be later after maybe they've got that a little bit, life is being affected?
I think it depends on what kind of individual you are. I think maybe having a meeting with the palliative care team so they can know who you are, know your situation, and develop a rapport. And maybe it's a one and done for a while. But I think that if the road starts to feel rocky, that's when it might serve you well to have more hands on board. I think perhaps, but people feel differently about it. Some folks that have good insurance that we could get them resources in the home that say, oh, I really don't want strangers in my house. And you think, oh, you're not so good at taking yourself to the bathroom anymore. So that's, worry about you falling, and you could have resources, but you don't want them. So I feel like when the road starts to get rough, for me, why not have those people get on board? And maybe they come and see you once, and maybe they don't. Maybe they come and see you next month or call you next month, and things are going well. You don't really need much from them right now, but then when you do need them, you've got them.
So does insurance pay for that?
Insurance does generally pay for palliative care. I'm not an expert on all of the insurances and what they cover. When I'm making a referral to palliative care for somebody, I encourage them to have that be part of the first meeting. Because when somebody from palliative care comes out to your house to see you, you're not signed on to their service, right? That's part of what they anticipate will happen during the meeting. But you have a little bit of, give me some information about your service. Let me make sure it seems like a good fit. And before you sign on, so you get asked that specifically. But in a general way, palliative care is paid for by insurance typically. And in some insurances, I think might have a copay. And what does that mean? I'm not sure, but yeah, it's a good question to ask if you ever, get connected with a palliative care team.
Can the social worker help you help you direct you on answering these questions? Or is it up to the patient to know what their insurance does in this one?
I think the palliative care team, anybody on that palliative care team should be able to answer that question for you when they come out to your house. And social workers in general are just really great at knowing what your insurance covers. They've got all the, different insurances. They've got the phone numbers right in their work phone, and they can just call up, Becky at whatever insurance, so they are knowledgeable about insurance in general, but then, it's kind of like, I don't want, a social worker might not want to speak for Gentiva's palliative care service though, right? Because they don't like a social worker at the cancer center might not feel comfortable, probably wouldn't feel comfortable talking about palliative care team and what insurance will pay for them. So it is good. You can start that information, but I think it's good to get it directly from the agency. That's a good question. That makes me think of one other thing I'd like to share, because the question of when to get extra help on board with palliative care. I mean, palliative care should be fairly easy. I do hear a lot that, you get referred to palliative care too early. But from my perspective, what is too early? Because anybody with a chronic illness could, get connected with palliative care. A palliative care clinician worth their salt is not going to be talking to somebody who just got diagnosed with an illness about their hospice preferences. That wouldn't make sense. Right. But when I'm talking with folks about hospice and they're asking, if somebody qualifies for hospice and they're asking, well, when should I sign on? To me, the question about hospice is, when do you feel like you do not want to return to the hospital if something happens? Because if you don't feel like you want to go back to the hospital, and when you have an end stage chronic illness, going back to the hospital a lot of times, we can take blood and we can do x-rays and we can give you antibiotics and IV fluids, and we can take you to different, units in the hospital. And a lot of that, we're just tinkering when you have an end stage chronic illness. We're just tinkering with stuff. We can take away these drugs and add these drugs in and maybe switch an antibiotic over or something. We're just tinkering around. There's not a lot that we can do to help somebody function better when they're at an end phase of an illness. And so some of those folks feel like, well, I could tinker around at home, right? You could call me a hospice nurse, keep me home, something flares up, hospice comes to me, patches my issue up, and I get to stay home instead of getting pulled out of my house, my family, my dogs, all of that. Yeah, and so to me, when it comes to hospice, that might be your biggest indicator of, gosh, the hospital's no longer helping me, why would I want to go back there? But of course, palliative care, I'm thinking, well, what's the harm? Just meet with palliative care and see what they have to say, right? Because you're not signing off of any, you're not getting rid of any medications or losing out on any resources. The palliative care should be helping you get resources and, helping to clarify and navigate for you. But some people are really savvy and they feel like they don't need that until, stuff gets more rocky. So I think it's an individual choice. Ultimately. Did that do it? Any other thoughts, questions?
Thank you, Toni.
All right.
Thank you.